Hi everyone, our group project's topic is machine learning, a random forest for predicting potential diagnosis of childhood asthma. And it's presented by Caitlin, Janali, and myself, Fatima. We're going to talk a little bit about asthma. It's a global health problem affecting an estimated 262 million people in 2019. And what's more interesting is it is the most common chronic disease among children. And it is often underdiagnosed as well as undertreated in mostly developing countries. So not a lot of people even know that they have asthma, and so it's hard for them to control the symptoms and manage the symptoms as well. So machine learning can be used to develop an early warning tool that can help predict the prevalence of asthma. This tool is an this this tool could enhance asthma management as well as it can reduce the likelihood of serious consequences, and it offers the potential to develop an early warning tool, and it takes different risk factors such as input and then outputs the probability of an adverse outcome, and therefore you can predict when you can get attacks as well as you can predict if this person has the likelihood of getting asthma. Asthma attacks particularly occur in those individuals with poorly controlled disease. Asthma doesn't have any cure. It's basically you have to just manage the symptoms. The symptoms include coughing, wheezing, chest tightness, etc. And this is all, if it's not managed properly, then it leads to severe asthma attacks. A lot of data has been used to investigate the use of machine learning to predict these attacks, such as EHR data. There's also genome data, medical images, wearable data from like the Fitbit or the our watches, and that has been used to create these machine learning systems. Not not many models have been created. That's why the primary focus is to provide a better understanding of this disease, so these systems can be created and asthma the amount of attacks can be reduced as the prevalence of asthma has also been on the rise, especially in children. So how we would fund this program is by using the CDC's National Asthma Control Program or something similar to that as well. This program was created in 1999 to help millions of patients feel better and better control their asthma symptoms. This program follows an exhale strategy. It also follows something called a surveillance program, and we would talk about that more. Currently, it funds 29 programs to improve asthma control services. It provides different services where you can manage your disease. They also go to schools and educate people about asthma and asthma symptoms. The exhale strategy means education on asthma self-management. The X is the extinguishing smoking and exposure to secondhand smoke. This is a very important factor in asthma symptoms. Home visits for trigger reduction and asthma self-management education. A lot of the asthma control, symptom control is basically by the patient himself or herself. And the home visits, the surveillance acts as home visits where they track if the patient is taking their medications, if the patient is staying away from environmental factors, and they also see if their environment is a good environment to live in. Achievement of guidelines-based medical management. So the CDC has come up with different asthma control resources, and it's called asthma evaluation resources, where they have ebooks and they have training modules where the public health administrator or whoever the provider goes through these guidelines, and they help evaluate if the person is in good health or if the disease is being managed properly. Linkages and coordination of care. Again, the program trainees or and public health providers are in coordination with their actual physicians and their asthma care providers, and they have a link as well. Environmental policies or best practices to reduce indoor and outdoor asthma triggers. One of the since 1999, and in once they gave awards to these 29 programs, one of the main policies that they've come up with is reducing air pollution because that is a big factor in triggering asthma symptoms. CDC's funding has played a key role in enhancing this quality of asthma care, especially in schools. There's a lot of education and training programs. There's a lot of awareness going on in schools because, again, it happens a lot in children. And as I said, air pollution reducing policies are being worked on. These are notable outcomes of this particular program.
The original dataset consisted of around 2,000 patient records and 29 columns, which after pre-processing was transformed into a dataset of around 1,000 records and 24 columns. Data types consisted of integers and floats. You see a word cloud shows the inclusion criteria, which included features for the model, such as age, less than or equal to 17 years old. The dataset included only the minimum age of 5. Sensitive features included our gender and ethnicity. Other included features are lung function, which is a clinical diagnostic measure, which was kept due to feature importance. There are mixed findings in the literature related to the significance of this measure, with a retrospective cohort study evaluating suspected diagnosis of asthma for children between the ages of 5 and 18 found higher sensitivity in diagnosis by just clinical evaluation, such as wheezing, dry coughing, exercise-induced shortness of breath symptoms. Additional symptoms such as chest tightness have been used in the diagnosis of asthma. Limited research could be found for the feature that we have of nighttime symptoms, and the data source did not provide clarity, but due to feature importance being high, it was kept. Medical history such as family history, history of allergies, eczema, hay fever, and lifestyle factors such as BMI, diet quality, physical activity, and sleep quality were included based on associations found to wheezing or potential risks for asthma. Additionally, environmental factors such as pollution, pollen, dust exposure, and pet allergies are significantly associated with childhood asthma. Education level was excluded as this feature associated with high school and higher education, which does not match with the age bracket of that we have of 5 to 17 in our model. Smoking, described as lifestyle factor and status, was removed due to low feature importance and based on the inclusion age criteria used. GERD was excluded as a systematic review completed show no significant association between childhood asthma. Last, there was a column, a doctor in charge, which had no relevance to the asthma diagnosis, and then the column diagnosis was used as our target variable. So we're going to go into data preprocessing exploratory analysis. Class imbalance can introduce bias into the model. Synthetic minority, I'm going to start that over. Okay, so we're going to start the next slide, we're going to go over data preprocessing and exploratory analysis. Class imbalance can introduce bias into the model. Synthetic minority oversampling technique was applied to balance the distribution of diagnosis and non-diagnosis for asthma. Additionally, sampling bias results from a particular group being underrepresented. Is something to look out for when knowing if a machine learning model is ready for use. Sensitive features such as gender and ethnicity should be explored to prevent any unfairness. There are different resampling approaches, resampling by group size or by proportion. For example, gender male, the count is 730. Female is 352. Oversampling female to meet that count of male, 730, would be considered sampling by size, while proportion of diagnosis and non-diagnosis was balanced within each subset of gender and ethnicity. For example, for males, the count of 730, the diagnosis and non-diagnosis was split 365 each. Based on the literature review, balancing by group size may not effectively reduce bias, but resampling by proportion has shown to reduce bias among genders. This is important as when sensitive features have feature importance. By the way, feature importance is where features impact the model's performance. The correlation matrix on the right-hand side shows that there is not high correlated variables, which is not necessarily a bad thing. Highly correlated variables can introduce noisy data and can cause overfitting. Based on the literature for machine learning random forests, highly correlated features have been removed to prevent the effects of multicollinearity, where too much similarities among the independent variables can skew outcomes. We used Jeffrey's amazing statistics program, JASP, for further exploratory analysis of potential models to use on our dataset. The software has a useful feature for different machine learning classification algorithms with no code needed. This allowed easy analysis of the models. 4 models were reviewed between decision tree, k-nearest neighbors, random forest, and naive Bayes. Random forest yielded the highest accuracy of around 94%, among other evaluation metrics. We decided to research more on this algorithm and find out if the implications and usefulness to our data set. Random forest classification was used. So the description of random forest consists of several decision trees. Each tree is trained on a subset of the data with a final classification taken by majority of vote from all the classification trees. Random forest is good as it efficiently explores a large set of features with a high prediction performance, captures non-linear patterns effectively without assuming the data's distribution, works well with mixed data types, resists overfitting, and handles highly correlated variables. It's also not influenced by extreme values and performs well with poorly separated classes.
We also used Python on the Jupyter platform to train and test the data to predict asthma diagnosis in children by using random forest machine learning model, as mentioned in previous slide. The development of data starts from pre-processed data, which is also mentioned in the previous slide. The data set was split into 70% training and 30% testing to ensure the model has sufficient data to learn patterns effectively, while reserving a separate data set to evaluate its performance and generalizability, achieving strong performance metrics, that is 98.3% accuracy, 98.2% F1 score, and 99.9% of EUC. Validation by confusion metric analysis helps to validate the model by providing detailed insight into true positive, true negatives, false positive, and false negatives, enabling assessment of classification accuracy and error types. ROC curve plotting validates model reliability by visualizing the trade-off between sensitivity and specificity across the thresholds, showing its ability to distinguish between classes effectively. In this way, this model can be ready for integration into the healthcare tools such as electronic health records and decision support system to facilitate early asthma warning and effective disease management. Due to the dataset being synthetic, the accuracy to feature importance is skewed. For example, pat allergy shows lowest, but based on the literature, has a high association to detecting the diagnosis of children asthma. Our research also concluded that not only does selecting the most appropriate machine learning algorithm impact the credibility of prediction, but the software used, such as Jupyter or JASP, can also affect organizational acceptance. As notes from Greg Moram presentation, 28% of companies face a lack of skilled personnel. Thus, depending on a company's skilled personnel and its strategic transformation toward AI adoption, no-code softwares like JAVS can drive efforts for initiation, experimentation, buying, and funding partnerships within an organization. Furthermore, there are barriers faced to the model capacity in determining potential diagnosis for childhood asthma based on potential selection bias from missing features. For example, maternal prenatal risk factors have been shown as a useful features in predicting childhood asthma risk. Other concerns include recall bias, where self-reported data from patient might not be as accurate compared to clinically determined. Last, overfitting was a consistent issue with our model. Contributing factor to this might be due to the small sample size. Efforts to mitigate overfitting should include implementing five-fold cross-validation within the trained data. And The further slides include references that we use for this machine learning group project. Thank you so much.